Okay, hello everyone. My name is Najwa Fitriah Binti Abdul Latiff. So today I will present about finger, which is PA and lateral finger using placement method. Okay, the first one is PA finger. Okay, for P is projection. I said it is PA projection for fourth finger because why I say it is not a thumb? It is because thumb only have a distal. Okay, you want to know where is distal, middle, and proximal phalanx? You can see in the radiograph. Okay, thumb didn't have middle phalanx, so in this radiograph it have middle phalanx. So obviously it is not a thumb. Next one, I said it is not third finger because I said it is not a third finger because the level of the MCP joint, the phalanx, the finger, the level of the MCP joint is higher than fifth finger and lower than third finger. Okay, I show you here. Okay, this is thumb. Wait. Okay, I put some. Okay. Thumb only have distal and proximal phalanx. Okay. This is I want to show you. Okay. Fourth finger you can see this. Okay. This finger, the MCP joint must be lower than this finger. Okay, and this is a third finger, so it must be the MCP joint must be higher than the fourth and the fifth finger. So it can be just like a stairs. Okay, if you can see here, the third finger, the MCP joint for this finger and this finger is same level, and the third finger have the highest MCP joint. Okay, next. Okay, why I say it is PA projection? Because first, phalanx are seen without foreshorten and metacarpals are not superimposed each other. Okay, you can see. Wait. This is PA. This is PA oblique, and this is lateral finger. You can see the difference at this part and also this part. Kalau PA, dia tak ada pun yang superimpose. Okay? We go to the next one. Next one is position. This positioning is correct because you can see the long axis of this finger align with and parallel to the side border of the IR. Midshaft concavity is equal on both sides of phalanx and metacarpal. Also, interphalangeal joint appeared open, indicating that hand was fully pronate. So you can see this is the difference between right and wrong positioning. This positioning is wrong because you can see the midshaft concavity. No. Here. Also dekat sini. Kat sini. Okay. Dia tak sama tau sebelah-sebelah ni. So, dia macam ada rotation laterally. Okay. So, finger is not into pronation. Kalau korang tengok point, dia punya joint pun macam tak berapa nak buka sangat lah kat situ. Okay. So, next we go to the alignment. The first one, alignment between X-ray tube and IR. Okay. The alignment between X-ray tube and IR cannot be determined because there is no evidence of collimation on all four borders of the film. The alignment between X-ray tube and structure also cannot be determined because there is no evidence of collimation on all four borders of the film. Okay, the next one is alignment between structure and IR. The alignment between structure and IR is incorrect because the distance between the central structure, okay, wait. The alignment between central structure here, no lah. Okay, it's okay. The alignment between the central structure, where is central structure? Central structure is the white dot, okay, to the edge of the film at superior part and inferior part is not equal. You can see the purple one is longer than the yellow one. Okay, next is, okay, in this radiograph, I cannot determine what central structure that they use. So I just want to tell you that the standard centering point for this projection should be at the proximal interphalangeal joint. Okay. Okay. Next is collimation. For collimation at the superior border, the structure should be included is distal phalanx, middle phalanx, distal interphalangeal joint. At the lateral borders should include concavities of phalanxes and metacarpal, half side of fifth finger and half side of third finger. At the inferior border, you should include proximal phalanx, metacarpal and metacarpophalangeal joint. So, there is no evidence of radiation protection apparatus seen on the radiograph. Okay, next for exposure factors. Okay, in this radiograph, the KVP and MAS use is we use KVP to look at the bony cortical outline and MAS to look at the bony trabecular pattern. The thick structure in this radiograph is proximal phalanx and thin structure is distal phalanx. So, for this radiograph, the bony cortical outline and bony trabecular pattern for the thick and thin structure is visualized. So, the KVP and MAS use is adequate, so there is no change needed. Next one is marker. In this radiograph, there is no evidence of anatomical marker. The radiograph there is a digital marker. Okay, the marker should be placed at the right side of the body at the appropriate area and not superimpose any region of interest. For aesthetic, the film size is 18-24 cm, which is sufficient to demonstrate all structures of interest, and there is no evidence of artifact on the radiograph. For patient's name, okay, the patient's name, ID, date and place of examination are not visualized on the radiograph. Okay, the patient's name, ID, date and place of examination actually should be clearly visualized on the radiograph at the appropriate area and not superimposed to any region of interest. Okay, the conclusion for this PA projection of finger is not acceptable because there is no patient's name, ID, place and date of examination, and there is also no marker evidence on this radiograph. Okay, next one we proceed to lateral finger, also using placement method. The first one is projection. This is radiograph of lateral projection of the fourth finger. Okay, why I say it is not a thumb? Because same like before, phalanges and metacarpals are seen in the middle of the radiograph. Also, you can see because it have a middle phalanx, kan? Okay. Next, why it is not a third finger? Because the level of PIP joint higher than fifth finger and lower than third finger. Okay. So, kalau korang tengok kat sini, sebenarnya kalau third finger pun kan, dia akan jadi macam ni tau. Dia takkan ada satu lagi jari kat sini. Sebab dia jari tengah. Kalau korang tengok kat sini, sekejap. Dia ada satu jari kat sini. Kalau kata dia nak buat projection tu, buka jari dia macam ni pun, dia akan ada dua jari. Satu, dua. Okay? Okay, so you can see this is different. This is lateral thumb and third finger lateral. Okay, why I said it is lateral and not PA? Because metacarpals can be seen superimpose each other, and you can see the posterior part of the finger can be seen without foreshortening. Okay, in the green box is the metacarpals, and at the red arrow is the posterior part of the finger. Korang boleh tengok dekat posterior part finger ni no concavity. At the anterior part have concavity. So obviously it is a lateral finger. For positioning, the positioning is correct because the concavity of the anterior surface of the phalanx can be seen clearly. Macam sebelum ni saya cakap. Okay. And the interphalangeal and metacarpophalangeal joint open, so that indicate that the finger is fully extended. You can see in the purple box, the interphalangeal and metacarpophalangeal joint are open. Next one is the difference between right and wrong positioning. Okay, this one is this one is the right positioning. This one is wrong positioning. Kenapa kita kata dia wrong? Okay, sebab this finger is not fully extended, and you can see the joint is not open well. Okay. Next one is alignment. Alignment between X-ray tube and IR cannot be determined because there is no evidence of collimation on all four borders of the film. The alignment between X-ray tube and structure also cannot be determined because there is no evidence of collimation on four borders of the film. Alignment between structure and IR also same like before. Okay, it is incorrect because the distance between the central structure to the edge of the film at the superior and inferior border is not equal. The central structure to the inferior part is longer than to the superior part. Also, in this radiograph, we cannot determine what the centering point that they use. So, the standard centering point, it should be at the proximal interphalangeal joint. Okay, next one is collimation. The collimation here at the superior border should include distal phalanx, distal interphalangeal joint, and middle phalanx. At the lateral borders should include anterior surface of proximal phalanx or anterior surface of the proximal phalanx, which is the midshaft concavity. The proximal phalanx of fifth finger and metacarpals. At the inferior border should include proximal phalanx, metacarpal phalangeal joint, and metacarpals. In this radiograph, there is no evidence of radiation protection apparatus seen on the radiograph. Okay, for exposure factors, as I told before, the KVP is used to look at the bony cortical outline, and MAS is used to look at the bony trabecular pattern. For the thick structure is proximal phalanx and thin structure distal phalanx. In this radiograph, the bony cortical outline and bony trabecular pattern for the thick and thin structure are visualized. So, we can conclude that the KVP and MAS use is adequate and there is no change needed. Okay. For marker, there is no evidence of anatomical marker in the radiograph. Marker should be placed at the right side of the body at the appropriate area and not superimpose any region of interest. Actually, the marker should be used is plumber marker. Okay. For aesthetic, the film size used is 1824, which is sufficient to demonstrate all structures of interest, and there is no evidence of artifact on the radiograph. For name, there is no patient's name, ID, date and place of examination in this radiograph. The patient's name, date, ID should be clearly visualized on the radiograph at the appropriate area and not superimpose any region of interest. So the conclusion is this radiograph also not acceptable because there is no patient's name, ID, place and date of examination, and there is also no marker evident on the radiograph. Okay, that's all from me. Thank you to Miss Faika and my fellow friends. Assalamualaikum.